It got really quiet in here. So we're going to go ahead and get started. I'm just going to do a quick introduction. I have everyone's name up here on the slide in order. Hopefully I didn't screw up the seat assignments. But we have Joyce Marshall, who is the Director of Maternal Child Health at the Oklahoma State Department of Health. And we have Dr. Lancer Stevens, who is a professor with the College of Public Health. Roseanne Smith is our state breastfeeding coordinator for the Oklahoma Health Department WIC service. Kamisha Busby is the director of Healthy Start Oklahoma City. And Dr. Kate Arnold is a fourth-year OBGYN resident here at the OU Health Sciences Center. And Barbara O'Brien is the director of the Office of Perinatal Quality Improvement, and she's going to be moderating the panel. So they each have some kind of points they're going to initially address, and then we have maybe some questions for the group, and y'all can ask some questions too. Hey, Barbara.
Okay, is this working? Can y'all hear me? Sounds like it's working okay. Welcome, and I'm excited to be facilitating this panel today, and hopefully we'll learn some more about what these different individuals, how they are working to improve the disparities that we see in breastfeeding. So we're going to start with Joyce Marshall. She is, as Becky said, the Director of Maternal Child Health at the Oklahoma State Department of Health. So Joyce, in your role as MCH Director, please address how the Oklahoma State Department of Health sees disparities impacting infant mortality in Oklahoma.
Okay. Thank you, Barbara. Can everyone hear me? Is it working? Okay. First of all, I want to say as I look out into this audience, I see so many of you who I know work every day to address these items, and you show how much you care and want to make that difference, and it is very much appreciated. Because the child's well-being really begins before birth. They begin to develop intellectually and physically at that time. And infant mortality is defined as the death of a baby that is less than 1 year old. And one of the factors that is considered in looking at a nation's health status is the infant mortality rate, because that looks at how they are looking at new generations, and so it is really taken into account as an indicator of a nation's health status. The United States doesn't do so well in that. We're ranked 31st among 34 industrialized countries in infant mortality, and the infant mortality rate for Oklahoma has remained above the national average since 1992. According to the America's Health Rankings, we currently rank 41st in infant mortality in the nation. And to make matters worse, inequities and disparities continue to persist, both nationally and in our state. This is not acceptable. Through the Preparing for a Lifetime, it's Everyone's Responsibility program. Okay, is that better? Great, okay. Through the Preparing for a Lifetime, it's Everyone's Responsibility program, numerous partners are working through the state to address disparities and inequities and make things better. We have learned that social determinants of health, such as education and income, are often major contributors to racial disparities found among women. Studies have found that among women with the same health insurance plans and similar income levels, African American women were less likely than white women to use primary and prenatal care services. Other contributing factors in birth outcomes include social class, education, poverty, and the chronic exposure to stress linked to racism, which reduces the mother's physical and psychological health. These statistics suggest that focusing on health and the social determinants of health prior to pregnancy and across the life course, outcomes for women and infants can be improved. I want to share some of these discrepancies with you, some of the disparities and inequities that we're seeing racially and ethnically in our state. Infants of African American and American Indian women are more likely to die before their first birthday than white or Asian infants. Additionally, preterm births and maternal mortality are higher for African American women compared to white mothers. Pre-pregnancy folic acid use is the lowest among African American and American Indian mothers, lower than 30%. Mothers with pre-existing conditions such as diabetes and hypertension prior to pregnancy requires several lifestyle modifications, including diet, exercise, and medications to reduce their health risks. The higher risk for African American women for high blood pressure and hypertension is well documented, as is the increased risk for African American, American Indian, and Hispanics for diabetes when compared to whites. Hispanics also have the highest teen birth rate at 54.9 births per thousand, while Asian Pacific Islanders are the lowest at 20 births per thousand. Smoking in the last trimester of pregnancy, there's a huge difference. It's highest among the American Indian at 40.9% and the lowest among Hispanics at 10.5%, almost a 4 times difference. This affects the critical area of breastfeeding also. Hispanics have the highest breastfeeding initiation at 88%. And they also have the highest duration for 8 or more weeks at close to 60%. However, African American mothers have the lowest duration at 8 or more weeks at just over 40%. Additionally, you would think this is enough disparities, right? But unfortunately, they continue to exist, and there's several reasons. Members of racial and ethnic minority groups and patients of lower socioeconomic status are likely to report being the subject of negative attitudes and discriminatory practices during the healthcare process. According to our Oklahoma toddler survey, 11.8% of mothers of 2-year-olds reported some form of unfair treatment when accessing healthcare for their child. The ability to pay was reported as a common reason for the unfair treatment and discrimination, and black mothers, unmarried mothers, and mothers less than 25 years of age reported the highest rates of discrimination. They also had a significantly lower rate of medical home access for their child. These disparities persist despite considerable progress in the delivery of healthcare services and efforts to improve the quality of patient care both nationally and in Oklahoma. Raising public and provider awareness about existing disparities, including how unfair treatment influences the likelihood of continuing care and accessing needed services, is an important step in improving the quality of health care for all. Some recommendations from our surveillance and research include evaluating and utilizing methods to get health messages to families and communities to better impact the populations they serve, make them relevant to the population and where it addresses them, similar to what Sherry said, making those messages relate, showing women of color breastfeeding in all of your messages so they can see themselves in those. Identifying systemic racism with the policies of agencies, programs, and health systems and working towards eliminating contributors. Partnering with existing programs to reducing poverty and providing educational programs for women and young girls of all ages, ethnicities, and races. And hosting focus groups to really hear directly from the various populations what the issues are surrounding health disparities and racism directly from them, and then working with them to make it a better place for all. Because our ultimate goal is for all babies of all races and ethnicities to be as happy and healthy as possible and to be able to celebrate not only their first birthday with their families, but for many years to come.
Okay, thank you, Joyce. Moving down the line. Question for Lancer. In your role at the College of Public Health, what have you seen in the way of inequities or disparities in treatment of American Indians. And if each of you all could hold the microphone at your mouth, that would be helpful.
Can you hear me? Good morning, everyone. Good morning. It's good to see everybody here today. So the question is, in my role as the College of Public Health, or in the College of Public Health, what have I seen as far as disparities with American Indians? It's not necessarily in my role at the College of Public Health that I've seen these. It's just a matter of life, growing up as a Native American and seeing the inequities that this population has, not only here in America or in Oklahoma, but also in America. So, quick question, Penny, you can't answer this. How many tribes do we have here in Oklahoma? How many federally recognized tribes are headquartered here in Oklahoma? Shout it out. We're all over the place. Penny had it correctly. We have 38 federally recognized tribes here in Oklahoma. Now, for those of you who didn't know that, how many people thought that Chickasaws owned Oklahoma? Right. And so that's kind of one of the points I wanted to make. We have some tribes that are doing very, very well in the community, and they're doing great PR, and they're saying we are Chickasaw, or we are Choctaw, or we are Cherokee. Well, that's great for those tribes, but we have 36 other tribes that are really struggling. And I think that those messages, while positive for those specific tribes, have done a disservice to the other tribes. I know everyone knows about the museum up here that's failed miserably. And the legislation, as well as the voters, have said, well, the tribes have money. Let them do it. Let them pay for it. Let them finish it. And it just brings angst to those people that they don't have the money. They're struggling on a daily basis. And Joyce hit it primarily on the head with all the inequities that we see in the healthcare. You know, as I mentioned before, some tribes are doing very well, but the majority of the tribes, the huge population of our tribal people, are not doing very well at all. The smoking rates, diabetes rates, obesity rates. It's very sad to hear about the infant mortality rate and things of that nature. So going back to the health disparities, it's not something that I see at the College of Public Health in the work that I do there. It's just a matter of life, of living, of seeing my younger generations having children, giving children away, having more children, giving children away. And when I say giving children away, I don't mean giving them away for adoption. I just mean giving them to whoever will take them. It could be grandma, grandpa, it could be aunt, uncle, it could be something of that nature. And I think a lot of it deals with just education. We need to educate our younger generations that this is not necessarily something that we should do. And it's a cultural thing as well, because we love kids. We love babies. When you see a baby, you feel good, do you not? And you get attention, do you not? But then that kid, and I can say this because I have 4 of them, they don't get cute so much. And so that little baby feeling goes away. It goes away. And, people that's all they have is that I don't want to say, but they get that pride from having that newborn. And when that pride goes away, what are they going to do? They're going to look to fill the void and have another baby and get that pride again for a few years. And then the cycle goes on and on and on and on. Speaking personally, I was at a family gathering just over the holiday, and one of my nieces made the comment. There was her and her sister, and her great-grandmother was there. And she said, Grandma, or great-grandma, between my sister and I, we have 9 kids. And she was really proud of that. And Grandma was proud of that, too. I wasn't proud of that because these kids are growing up in poverty. And, I'll see them come to the house, and I'm like, why aren't you in school? Well, we're not going to school today. It's not important to us. And it's really sad. It really is sad. And so you ask yourself, well, he's a professor here at the College of Public Health, and this is happening in his own family. He must not be very good. Well, Penny could probably agree with that statement. But the reality is it's really hard. It's really hard. And as I look in this audience, I'm going to tell you what's wrong with this audience right now. Look around. There is no men. Not to say you're not a man, or yeah, okay, all right. Hey, you're a man. You're a man. There you go. But the reality is that there's no men here, and I can speak personally about this. I know nothing about breastfeeding. As I was telling Kate, I think it was fun when I was a kid, but I don't remember it. I don't remember it. And the people that make the policies that make it able for women to breastfeed in their workplace and their jobs, without having that stigma associated with it, being low in production or something of that nature. These people, they need to be here. They need to understand what their message is, because, as Joyce said, it's huge. It's huge to the breastfeeding. And we all know, I mean, most of us here know how important it is as far as building up the child's immunity and things of that nature, as well as the bonding. And so, again, I guess to go back to the question, in my role at the College of Public Health, I see a lot of inequities and disparities, but it's life. It's life. Right. Thank you.
Thank you, Lancer. And Roseanne, in your role with WIC, please address how disparities and inequities impact the families that WIC serves.
WIC is just a great program because it really addresses a lot of the health issues that we're talking about. It really is a safeguard for our families. WIC has been around for, this is the 42nd year, and I've been working in WIC over 20 years. And I love WIC because we do connect with the families. We do address some of their issues or lack of support. And WIC is a great place to come to find out where they